Okay, so chapter 44 is end of life care. We are all going to death at some point in your careers, especially if whether you're an aide or whether you're a nurse. So you really need at some point to reflect on what you believe about death, how you feel about death, and the effects of death and how they affect you, because that affects the care that you give someone. So let's go on here. Okay, so end of life care describes the support and care given during the time surrounding death. It can involve days, it can involve weeks, or even months. It just depends on the situation. But sometimes death is sudden, but often it is expected. So again, your feelings about death affect the care you give. So you need to understand the dying process. And then you can approach the dying person with caring, kindness, and respect. You'll help meet the dying person's physical needs, their psychological, social, and spiritual needs. That's what we try to do. And so, again, everyone at some point in their careers are going to see death, and sometimes often depending on where you're working. And a lot of times, that's why you need to explore your feelings, because a lot of people are really unsure of their feelings about death. All right, get this thing to go forward. So, an illness or an injury for which there's no reasonable expectation of recovery is a terminal illness. Okay, so terminally ill people basically are going to die at some point in the future. Um, so, hope and the will to live strongly influence living and dying. Some people are afraid of dying and they will want everything in the world done to keep them living. But at some point, they may have to face it, but they may not accept it. So accept dying. So this will to live, I mean, it's amazing to see what the will to live, how it influences a person in the dying process. So I'm getting off track, so let me get back on here this thing. But it really is quite amazing when you get into end of life, um, what it is, how it affects people, how it affects you, and just all types of issues that are associated with it. But there are types of care that we give, and palliative care just involves relieving or reducing the intensity of uncomfortable symptoms without producing a cure. So palliative care then is just we can give them pain medicine. We know they're going to die. We're going to keep them as comfortable as possible. We're not going to be doing all this unnecessary stuff like weighing weekly or weighing daily, because we know that there's an end coming. Okay, hospice care on the others on and palliative care means we can give them things that doesn't have to really deal with IVs or anything like that. It can, but palliative care is different in that hospice care focuses on the physical, emotional, social, and spiritual needs of the dying person and the families. And basically here the goal is to improve the dying person's quality of life. So, many people have died with no apparent reason when they lose hope or the will to live. And I actually didn't know this until my grandmother died, but I had an aunt. My uncle divorced her, and my aunt said she died of a broken heart. And you can actually die of a broken heart. That really is true, because she didn't have a will to live, because she really loved my uncle, and he had fallen in love with someone else. So, you know, that will and that hope to live, that hope are extremely important. And then persons with terminal illness can choose palliative care, which or hospice care, and they might opt for palliative care and then change over to hospice care. It just depends on what's going on with the patient, how much pain they're experiencing, because again, a lot of this has to do with pain and the uncomfortable symptoms that occur with some types of death. or conditions that cause death, I should say. So the intent of palliative care is to improve the person's quality of life and provide support for the family. And this care is for anyone with long-term illnesses that will cause death. Sometimes you hear it called comfort care, where we just keep them comfortable. Often the person in hospice care has less than 6 months to live. If you're going to be on hospice care, the terminal illness has to be within a year or they'll take you off hospice care. And it doesn't mean that you can't have palliative care. It just means you won't have what is certainly called hospice care. And it has a lot to do with payment systems. But for the most part, these persons who are on hospice care really do have less than 6 months to live. And no attempts are made to cure the person. Hospice care is not there. They're not concerned with cure or life-saving measures. Pain relief and comfort are stressed in hospice care. So hospice will provide support for the health team to help deal with a person's death. Like today, I believe one of the patients on the unit that you cared for was on hospice care. And part of hospice is they'll have an aide who comes in and gives the bath. So that means the aide in the facility doesn't give the bath that day. That hospice aide will come in and do it. And that's really, you just have to look and see what's on the care plan as far as if they're on hospice care versus palliative care. So let's talk about attitudes of death or about death. So your experiences, your culture, your religion, and your age all influence attitudes about death. And our attitudes about death can change over time or as a person grows older and depending on our changing circumstances. So practices and attitudes about death really differ among religions. Um, Often the family really is involved in the person's care and they usually gather at the bedside to comfort the person and each other, especially towards the very end of that person's life. And then when death occurs, what we'll do is the funeral director is called and he or she will then take the body to the funeral home to prepare for funeral practices. Okay. Um, and of course, depending on the culture and the religion, there are some other things that can go on here. So you would have to know what they want done. So let's talk a little bit more about that because it really does come into play a lot. So cultural and spiritual needs, would be any practices or attitudes about death, and that differs among cultures. So like Catholics, if the person has a impending death, then they want the last rites prayed over them, and that usually is given by a priest. So a lot of times, even after death, they will have special prayers to say. So, that I'm familiar with the Catholic religion, so I'm familiar with what the cultures or what that culture wants. But every culture is different, so you have to, when you people with different cultures, you would really want to go along with what they need to do. Like I believe in Jewish cultures, once the person dies, it's the body is never left alone. Uh, one of these Jewish leaders will come and stay with the body the whole time. So all differs. So attitudes about death are closely related to religion, and reincarnation is the belief that the spirit or the soul is reborn in another human body or in another form of life. And I think of Hinduism, I believe, believes in reincarnation. Many religious practices have different rites and rituals during the dying process and at the time of death. So it's very interesting if you're not familiar with culture to read up on it and what all they do when someone dies. If you're as far as just self-learning, it's really quite interesting. So age also affects a person's attitudes and feelings about death as well. We're invincible, nothing's ever going to happen. But as we get older and older, you may not be thinking about death very much at this point in your life, but at some point, your mortality or your feelings about mortality are going to be affected and brought into the forefront for you to review and see what you're feeling about that. All right. So when a person dies, we say they go through stages of dying. And Dr. Elizabeth Kubler-Ross described the 5 stages of dying, which denial is the first stage, anger is the second stage, is the third, depression is the fourth, and acceptance of death last. Now, a person can be go back and forth between these stages, or they can even get stuck in one stage. So as long as you kind of understand. So like you went to the doctor and the female, you had a lump in the breast, they did a biopsy and it came back as this very bad cancer that is advanced. So denying that there is kind of the first stage. And you know, we all have kind of that shock value is, whoa, your whole world is turned upside down, you know. So there's some denial. And then there's anger, especially if you're younger. Why did this happen to me? I don't understand. And then bargaining is like, God, if you'll just let me have this little bit more of time, or let me see my daughter graduate, or let me see my grandchild born. This is a bargaining type of stage. And then depression is they're just very sad about the things they may have done in the past that they wish they could redo, sad about that they are going to die and that they're not going to be on this earth any longer. All those things can contribute to depression. I mean, that is all part of depression. And then acceptance of death is that they've accepted it, that they maybe like make funeral arrangements for themselves, or tell their people what they want done. This can all be part of acceptance of death, and that's usually the last stage. But again, not dying persons do not always pass through all 5 stages. Again, they can get stuck. They can go today, they can be bargaining, tomorrow they'll be angry, the next day they'll be sad. You know, they can go back and forth through the stages. So comfort needs. Um, let's see. In comfort needs, end of life care always involves addressing a physical, mental, emotional, and spiritual need. And I'm sorry, I'm going to have to cough, so hang in there. I'm going to turn the mute on, and I'll be right back with you. So I'm going to start back over. End of life care involves addressing the physical, emotional, mental, and spiritual needs. So comfort goals are to prevent and relieve suffering to the extent possible. Now, say a person has bone cancer, and bone cancer is a very, very painful cancer. It's not the only painful cancer in the world, but it is very, very painful. Are we going to relieve all that pain? Absolutely not. But maybe we can take it down a notch or two to where it's more tolerable and the patient can experience maybe some restful sleep or some time to talk with their family. It all has to do with what they want and what they feel the quality of life that they want to have. So always respect and follow their end of life wishes. Um, they may want to see a spiritual leader. Maybe that's a priest. Maybe that's a rabbi. Um, maybe that's a preacher, or whatever religion denomination they go to. And we would try to reach those specific persons for them. And we want to make sure that you provide privacy during prayer and spiritual moments. So maybe you're in the room and you're taking care of the other person and you're done with their care. But the teacher is there and he's getting ready to say a prayer. The thing for you to do is just to stand quietly until he's done before you leave the room to afford them some privacy. And always be courteous to your spiritual leaders, whoever they may be. You may not. It's always good to be courteous to everyone, but you know, you want to do that and handle the person's religious objects with care. And there are lots of different objects they may have. You may not understand them, but if they've indicated that this is a religious object, then by all means make sure that show respect and care with it. Let's see, as far as physical needs go, dying can take like a few minutes, hours, days, or even weeks. And to the extent possible, independence is allowed. But usually, as they get closer to death, they become weaker, and we pretty much take over all care and provide care. But every effort is made to promote physical and psychological comfort. And that's making sure that their skin is clean and dry, that their beds are free and linen is clean, and they're in good body alignment. They're we want them as comfortable as possible, and also to promote comfort. That means repositioning them 2 hours, providing oral care, that type of thing. Those are the things that we do to promote that physical and psychological comfort. Touch is really quite important sometimes to certain people, whether it's stroking the arm or the side of the face or just telling them some type of comforting words. So basically, we want them to be comfortable as possible, and then the person is allowed to die in peace and dignity. For as far as pain goes, we want to if they're in pain, you want to make sure that you report that so that the nurse can assess them and give them, again, possibly some pain relievers. But we can do some things that don't require a medication, such as skin care or personal and oral hygiene or back massages, making sure they're in good alignment. And of course, those frequent position changes and even supportive devices, those pillows, like those wonderful pillows we used for alignment, they come in really handy. They can also experience some breathing problems, so you might they might have to have the head of the bed up. Or vision, hearing, and speech, their vision will blur and gradually fail. Their hearing, again, it's one of the last functions lost, so you continue to talk to them in comforting tones. Um, their speech can become difficult. You may not be able to understand what they say. Go to yes, no questions if you need to try to understand their wants and needs. Um, Always again explain what you're doing. And when it says breathing problems, usually the breathing does become affected. They're breathing less or they're breathing shallow. They might have periods of apnea. We talked about that in respiratory. Remember, semi-Fowler's position is usually best for breathing problems. Okay. Um, the person will naturally turn towards light. So, in a darkened room can be frightening. So, have adequate lighting. Doesn't have to be the big bright fluorescent lights, but, a nice lamp on. Again, I always explain what you're doing and assume that the person can hear you. And of course, sometimes you just have to anticipate a person's needs. So, as far as mouth, nose, and skin, again, oral hygiene, crusting and irritation of the nostrils can occur, boogies basically. So make sure their nose stays clean. Their circulation fails and their body temperature rises as death nears. And when circulation fails, sometimes they get what's called mottling on their lower extremities. So they kind of look cyanotic and kind of going along the veins. It's kind of distinctive. It's hard to explain, but it's very distinctive if you ever get to see it. And usually that even tells you more that death is going to be very soon because the circulation is starting to shut down. As far as nutrition goes, you want to offer them something to drink, offer them something to eat, even if they choose not to. Um, they might have nausea or vomiting. Appetite will decrease, and those are all common occurrences. And of course, if they're nausea or vomiting, we can give them something medication wise to help that. But sometimes if they don't want to eat or they refuse to eat or drink, just basically document that and report it to the nurse. As far as elimination, they can start to have incontinence. So we would just, put bed pressures on or use some type of incontinent product, and of course, give good perineal care. And Sometimes they'll get constipated because, again, they're not moving as much and everything's starting to slow down and shut down. Urinary retention is another problem. If they have urinary retention, means they can't pee, we can put a catheter in. But we only do, you don't do that, but you might have to end up caring for it as far as like giving calf care and emptying the bag. Um, but they'll, uh, but they can assess for that, if, especially if they're uncomfortable. You can report that to the nurse and she can assess for that. As far as the room goes, it should be comfortable. It should be well lit and well ventilated. Um, any unnecessary equipment needs to be removed. You might have to put in an extra chair for the family, um, and just arrange the room so that the person and the family be together as they wish. As far as mental and emotional needs, those are very personal. And so some persons really have specific fears and concerns, like they're afraid of being in pain, especially severe pain, or when and how death will occur, or what will happen to loved ones, or dying alone. Um, those are all concerns not only for the patient, but or the resident, but also for families. Some families have never experienced a death and they don't know what's going on. So we try to inform them, and tell them what you're doing and why you're doing it, and what was. Uh, as a nurse, I can try to tell them a bit about what's going to happen, depending on the patient's condition or what's causing the terminal illness that they have. The doctor again can order medications for anxiety or depression for the resident themselves, but you can do things like touch, holding a hand, back massage, soft lighting, or music at a low volume. Those are all simple measures that actually can help soothe the person. It's all about kind of common sense and what would you want done for you in the context of their wishes. So with the family, it's also, again, it's a difficult time for them. They're usually allowed to stay as long as they wish. Just respect the right to privacy. You can't neglect others because the family is, or you can't neglect care of the patient just because the family is there. And the family goes through stages just like the dying person does. So they need support and understanding, courtesy, respect, all that good stuff. And then again, a spiritual leader can provide comfort for them as well as for the resident. As far as legal issues go, there is a Patient Self-Determination Act in OBRA, and this gives the persons the right to accept or refuse medical treatment, and also gives them the right to make advance directives. Okay, now advance directives, I think I've kind of mentioned it before, but way back when the beginning of the class. But an advance directive is a document stating the person's wishes about healthcare when that person cannot make his or her own decisions, like the living will. The living will is a document that about measures that support or maintain life when death is likely, and it also can give direction to the doctors and nurses about what the patient wants, what kind of measures they want. If the person is a DNR or a no code, a DNR means do not resuscitate. The person will not be resuscitated. They're allowed to die with peace and dignity, and the orders are written after consulting with that person and their family. Um, the nursing centers have to inform persons of the right to advance directives on admission. We go over that. The admissions process goes over that with the family and the resident. So usually from the beginning, we kind of know if they already have an advance directive in place or a living will. And I've already kind of explained to you about that durable power of attorney versus the power of attorney and all these other things. And we have to follow their wishes. We may not agree with them, but sometimes we just have to agree not to agree. But we have to follow what they want, even if you don't agree with it. You have to follow that person's or family's wishes and the doctor's orders. Da, da, da. Okay. Signs of death is our next slide. So now the very end. And signs of death can occur rapidly or slowly, but movement, muscle tone, and sensation are lost. Peristalsis and any other type of other gastrointestinal functions slow down. The body temperature rises. Circulation fails. The respiratory system fails. And pain decreases as the person loses consciousness. So the signs of death include there is no pulse, no respirations, and no blood pressure. And a doctor pronounces the person dead. A lot of times, um, what will happen in long term care facilities is one person can be, there's usually the director of nursing or some important bigwig who can sign off on pronouncements of death. Most of the time, a doctor does have to pronounce the person dead. But in long term care facilities, you know you're not going to have a doctor around the corner. Call all these necessary people to let them know that Mrs. So and so has no pulse, no respirations, and no blood pressure. And usually, the doctor and the other important people in the administrative persons of the facility are already expecting that this person is going to be die or the person is going to die. So basically, we give them care till the very end. They die. They notify all the appropriate people, including the funeral director, and sometimes it can be a coroner's case. We have to notify all the appropriate people when that person dies. Usually the family is there, but not always. I try not to tell people over the phone that their person has died. What we try to do is to say, this person's really taking a turn for the worse. Can you come in as soon as you can? And most of the time, they're right on it anyway. So what you do as an aide is you really care about the body. You've cared for the person until their death. Once they you're going to care for the body after death. And this is called post-mortem care. So it's after the death has occurred. And it begins when is pronounced dead, and it's done to maintain a good appearance of the body. So the person has a right to privacy and the right to be treated with dignity and respect even after death. So within 2 to 4 hours after death, rigor mortis develops. And rigor mortis is where the muscles stiffen and they can't be moved. So usually we've got our care done within that amount of time. So an autopsy sometimes is ordered, and that's an examination of the body after death to determine the cause of death. Let's see. When we give postmortem care, um, you can be asked to assist, or you might be expected to actually perform the postmortem care. And depending on, like, the person was expected to die, they had cancer. You're not going to get an autopsy. They're not a coroner's case. They knew it was coming, okay? So most of the time after that, the nurse might come in and take out any tubes that the person had in their body, like an IV tubing or the Foley catheter, okay? But we usually what we do for the body is that we clean them up. Like if when they die, they lose muscle tone. And without muscle tone, you can have a bowel movement. Okay, so we always make sure that they're comfortable. So you make sure you want to be wearing your PPE when you're doing this care. And sometimes we put a blanket over them, and or most of the time we do put a blanket over them. But some places have post-mortem sheets that they use. Um, and we get everything ready basically. We make sure their teeth are ready to go or their glasses are ready to go to the funeral home, and the nurse can give you instruction on what needs to go with them. But we try to put the body in a comfortable and natural position for viewing. We usually kind of do this and let the family come back in to say their last goodbyes if that's what they want to do. But basically, the body should appear in a comfortable and natural position for viewing. And then remember, I told you we all have extra air in our lungs times, okay? It's our reserve, it's our residual air. So when you turn the body over, any air in the lungs or even the stomach can be expelled. So you might, expect that. So if you hear it, it doesn't scare the peewad out of you. So you just want to be aware of that. Um, you know, they're normal and they're expected. So, nursing assistants and staff grow close to the people we care for. And when death takes them away, actually, when a resident that you're very close to, it can be a really very sad time for you. And sometimes just talking about it can be helpful. And again, just like with anything, healing comes with time, but it's also important to consider the feelings of other residents. So, you know, residents of the they want to know what's going on. So most nursing centers have a chapel where a memorial service can take place. And residents, like if they were roommates, they usually reminisce about that resident at some point, and it's your own way of healing. So as far as quality of life goes, we're all going to face that point of death at some time or experience it with another person. And the person has the right to die in peace and with dignity. So the dying person has these rights from OBRA, and so you should read over those because you might find a question like that on the test. Um, and I think that pretty much covers the end of life. If you've got questions, email them to me, or we can talk about them in class, and I'll talk to you soon.